there is a patient who is having complaints of abdominal pain. The pain is in the epigastrium and is radiating to the back. The history is that patient, there is a 30-year-old male who is having a history of chronic alcohol intake and is having complaints of recurrent abdominal pain in the epigastrium, which is radiating to the back and requiring injectable analgesics. The X-ray and CT of the abdomen was done, and this is the images which are shown. What is the diagnosis? The diagnosis here is chronic pancreatitis. Okay. Now, why this is chronic pancreatitis? You can see here in CT, in pancreas, there are multiple ductal stones and some parenchymal calcifications also. So, stones in the pancreatic duct or in pancreatic parenchyma on CT. They are classical features of chronic pancreatitis. Okay, now this X-ray, just see this X-ray properly. That there are arrows which are marking that there is multiple calcifications here. Few calcifications here also. These are calcifications in the head and as well as in the tail of the pancreas. And these calcifications can also be seen on X-ray as well as CT. And these calcifications are made up of calcium carbonate. Okay, sometimes they might give that there is a patient having complaints of abdominal pain, and there will be in the X-ray there will be calcifications which are along the midline, along the line of pancreas only. So they are asking regarding chronic pancreatitis. Okay. Now, what is chronic pancreatitis? It is inflammation of the pancreas, pancreatitis, for a longer period of time. Chronic pancreatitis. Okay. Now, this damage is chronic and irreversible, and it leads to an irreversible fibrosis in the pancreas. Now, we all know that pancreas is having exocrine function as well as endocrine function. So there is presence of endocrine cells as well as the acini. Okay. Now, damage to the acini leads to exocrine insufficiency, and damage to the alpha beta cells and other endocrine cells leads to, or the islet cells you can say, leads to endocrine insufficiencies. Generally, what happens is initially the patient will be having exocrine insufficiency, and gradually, if the chronic pancreatitis goes more severe or more prolonged, the patient will develop endocrine insufficiency also. The third component of chronic pancreatitis is development of chronic pain. Okay, so there is exocrine insufficiency, patient is having fat malabsorption, steatorrhea, and there is presence of diabetes, and there is development of chronic severe pain. Okay, so this is chronic pancreatitis. Now we will get the investigations done. Amylase and lipase are not important for chronic pancreatitis. Generally, the amylase lipase are not raised, and in fact, we can say that amylase is classically normal in majority of the patients. Okay. Now, how to diagnose chronic pancreatitis? We can get a CT done to see for pancreatic inflammation as well as pancreatic calcification. The investigation of choice is MRCP, and in case if we have diagnosed the chronic pancreatitis, if there is presence of ductal stones in the pancreatic duct, we can go via ERCP and we can remove these stones and we can stent the pancreatic duct. This will reduce the ductal hypertension, okay, and will improve the pain. If there is no response to the endoscopic therapy or the endoscopy is not possible, then either we'll have to go for surgery or we'll have to go for celiac ganglion block. Generally, in surgery we will do either a resection of the head of the pancreas or a drainage of the pancreatic duct, which depends on the CT findings. And pacemaker of pain is the head of the pancreas. That is why resection of the head of the pancreas as well as the drainage of the pancreatic duct is the preferred procedure. That is Frey's procedure, which is the preferred procedure in chronic pancreatitis. Okay, this is basic idea regarding chronic pancreatitis. Now, I will discuss it in detail. Okay, so now this is the imaging which I have shown, showing chronic pancreatitis. And now, what is chronic pancreatitis? Chronic pancreatitis, there is irreversible fibrosis of pancreatic parenchyma. So there is irreversible damage of the pancreatic parenchyma. Okay. There is presence of exocrine insufficiency, which occurs when more than 90% of exocrine cells, which are acini or acinus, are damaged. Okay. Endocrine insufficiency generally occurs when more than 90% of islet cells are damaged. Chronic pain occurs either due to the inflammation of the peripancreatic nerves or the plexus, or due to the head pancreatic head mass, which is actually the pacemaker of the pain, or due to the ductal hypertension, which is due to the obstruction in the main pancreatic duct. Exact reason is not known, as few patients they don't have a stone in their pancreatic duct, even then they are having pain. So the exact reason is not known, but these are the possible causes of pain in chronic pancreatitis. Now, this with this exocrine deficiency, the patient will have steatorrhea, because there is fat malabsorption and malabsorption, or indigestion, you can say. What is the definition for steatorrhea? When there is more than 7 gram per day fecal fat excretion. Okay. Now, endocrine insufficiency will lead to development of diabetes mellitus, and along with that, there will be pain. Among all the causes, the most common cause is alcohol intake. Most common cause of acute pancreatitis is gallstones. Most common cause of chronic pancreatitis is alcohol intake. Okay. Now, for causes of pancreatitis, there is a classification for etiology. This classification is TIGAR-O classification, and this TIGAR-O stands for toxic, metabolic, idiopathic, genetic, autoimmune. Then there can be recurrent severe acute pancreatitis, which can lead to pancreatic duct obstruction and can lead to pancreatitis. There can be obstructive due to any stone in the pancreatic duct, or due to any mass which leads to obstruction and which leads to chronic pancreatitis. Okay. Among the genetic causes, there is there is some genetic mutation which leads to pancreatitis. Genetic mutation. Now, hereditary pancreatitis occurs because of mutation of PRSS1 gene, which is cationic trypsinogen gene. Idiopathic chronic pancreatitis occurs due to mutation of CFTR gene, which is responsible for cystic fibrosis. Okay. And this tropical calcific pancreatitis occurs because of mutation of SPINK1 gene, also known as PTSI gene, or PTSI stands for pancreatic secretory trypsin inhibitor, or trypsin secretory inhibitor. So, SPINK1 is responsible for chronic pancreatitis. Yes. Which type of chronic pancreatitis? SPINK1 mutation is responsible for tropical calcific pancreatitis. CFTR for idiopathic, and PRSS1 is for hereditary pancreatitis. Okay. These are questions previously asked. Now, what is the clinical features? Most common clinical presentation is with abdominal pain. Abdominal pain is generally epigastric pain, which is radiating to back, that is pancreatic type pain. Other clinical presentations can be diabetes mellitus, presence of steatorrhea, or malabsorption. Okay, these are the general presentations in chronic pancreatitis. Weight loss, and what is the triad? The classical triad is obviously exocrine plus endocrine plus abdominal pain. So this is diabetes mellitus. Then there is steatoria. Then there is pancreatic calcification. This is the classical triad. In case if a patient is having diabetes mellitus, steatoria, exocrine, endocrine. Along with that, if there is presence of pancreatic calcification, then this is chronic pancreatitis. Presence of pain is not mandatory for the diagnosis of chronic pancreatitis. Okay. Now, in what happens in the pancreatic duct? Suppose this is a pancreatic duct. There is development of stones here in the pancreatic duct, or there is development of calcifications in the pancreatic parenchyma. Okay. Gradually, due to this obstruction, there is presence of stricture in the pancreatic duct and dilatation. There will be stricture and dilatation, then stricture, then dilatation, with some dilate and stones in between. Okay. So in on ERCP, it will give a picture of string of pearls or chain of lakes appearing. And this stone is calcium carbonate. And it leads to development of pancreatic duct stricture and dilatation. Okay, so there is development of pancreatic duct stricture and pancreatic duct dilatation. Few patients also develop head mass in chronic pancreatitis. Development of head mass in few patients, and this chronic pancreatitis is pre-malignant, and patient can develop CA pancreas. Okay. Now, on CT and X-ray, we can see calcifications. Calcifications are seen in up to 30% of the patients. Okay. Now, this calcification is seen in 30% of the patients. The diagnosis is generally made by CT scan or MRI abdomen. But the investigation of choice is MRI. Okay. The investigation of choice is MRI, and the gold standard investigation is ERCP. Okay, so the investigation of choice here is MRI with MRCP, but the gold standard is ERCP. Why ERCP is gold standard? Because we can remove the pancreatic duct stone also. Okay, okay, and on ERCP we are seeing a chain of lake or string of pearls appearance. Why we are seeing a string of pearls or chain of lakes appearance? Due to presence of pancreatic duct stricture, calculi, stricture, dilatation and calculi. Okay, that is why we are seeing a chain of lake or string of pearls appearance. This is how this looks on MRCP. So the investigation choice is MRCP with MRI abdomen. There is dilatation of the pancreatic duct. Here stone is not visible, but there is dilated tortuous pancreatic duct. Okay. The gold standard is ERCP, and on ERCP we are able to see a string of pearl or chain of lakes appearance. And in case if there is early chronic pancreatitis or very minimal changes of pancreatitis, that is best detected by EUS, that is endoscopic ultrasound. And for diagnosis of chronic pancreatitis by EUS, there is a criteria that is Rosemont criteria. So Rosemont criteria is for diagnosis of chronic pancreatitis based on EUS findings. Okay. Now, what is the treatment? So the treatment also depends on the three lines. Okay. So we'll have to manage the exocrine insufficiency, we'll have to manage the endocrine problems and the pain. For exocrine problems, we'll have to use PERT. What does PERT stand for? That is pancreatic enzyme replacement therapy. Okay, and we will have to give the exocrine enzymes. Okay, so generally we give the trypsin and chymotrypsin enzymes, and for endocrine insufficiency we'll have to give insulin for diabetes, and for chronic pain we'll initially start analgesics. For analgesics, the analgesics of choice in NSAIDs, it is metamizole. The same we are giving for acute pancreatitis, and in opioids, it is buprenorphine. Okay, this is regarding analgesics. Now, if the patient is having recurrent pain and is not responding to analgesics, we'll have to go for surgery. Okay, the basis of surgery is that there are two most important reasons for pain. First is ductal hypertension. Due to obstruction of the pancreatic duct or stricture present in the pancreatic duct, that is ductal hypertension. And the second is head mass or pancreatic head acting as pacemaker for pain. Okay, so these two are the main reasons. So for that, suppose this is a pancreatic, suppose this is the pancreas. Here we are having pancreatic duct like this. What we can do is we can open this suppose this is a you can say this is a roll, and we incise the roll, we open the pancreatic duct like this, and we'll have to anastomose jejunum. Okay, so that whole of the pancreatic juice without any obstruction will come straight away to the root of the jejunum. Okay, so this way we are opening the pancreatic duct and we are draining the pancreatic duct. So for ductal hypertension, drainage procedure is important. Okay, ductal drainage. And for head mass, either we can remove the pancreatic head, okay, that is either by a pancreatic head resection or a Whipple's procedure, that is a pancreaticoduodenectomy. Either a duodenum preserving pancreatic head resection, where only the pancreatic head is removed, or a duodenopancreatectomy, that is a Whipple's procedure. Or another way is we a combined procedure in which we'll open the duct and we will resect the head, and then we will join the jejunum in the duct as well as the head of the pancreas. Okay, so this is a combined procedure. So now I'll tell you the names of the procedures. There are three broad categories of the surgery. One is a drainage procedure, one is a resection procedure, and one is a combined procedure. So the drainage procedure is a Pusto procedure. Pusto procedure, also known as LPJ, or a lateral pancreatico jejunostomy. This is also known as a longitudinal, because we incise the pancreatic duct longitudinally, and pancreaticojejunostomy. Then in the resection procedures, there is a Beaker's procedure. Beaker's procedure is DPPHR, or you can say duodenum preserving pancreatic head resection. I'll show you the diagram. And the second one in resection procedure can be Whipple's pancreatic or duodenectomy, which we'll discuss in CA pancreas. Okay. Now this drainage plus resection procedure is actually can say a phrase procedure, which is local resection of head of pancreas with longitudinal pancreaticojejunostomy. This phrase procedure is the preferred procedure for chronic pancreatitis surgery. Okay. Now, what we are achieving with this surgery is relief in the pain. Okay. Not relief in the endocrine or exocrine insufficiency. In fact, after this resectional procedures, there can be an increase in the exocrine or endocrine insufficiency. Why? Because we are resecting the remaining portion of the pancreas. Okay, already there is damage to the pancreas, and whatever pancreas is remaining, we are removing a significant portion of the pancreas. So there may be increase in the exocrine or endocrine insufficiency, but in case if there is severe pain which is not responding to medicines, then we'll have to go with surgery. Suppose in case if the patient is not responding to surgery also, or in case if the patient is not a suitable candidate for surgery, in these cases we'll have to go for celiac ganglion block. Celiac ganglion block works on the principle that the pain is actually due to involvement of the peripancreatic nerves or the celiac ganglion involvement, and we'll input alcohol into the celiac ganglion, and this will resolve the pain. Okay, so there is celiac ganglion block which helps in resolvement of the pain in case if the patient is not responding to surgery or if the patient is not a good surgical candidate. Okay, now regarding the procedures, to make you understand, these are the diagrams which are very important. We just see here that this is pancreas and the pancreatic duct is opened. So we are longitudinally opening the pancreatic duct. The duct is opened like that. We will remove all the stones and we will open all the strictures. Then the root limb of the jejunum is brought up and is anastomosed to the pancreatic duct like that. Okay. So here first point, dilated pancreatic duct is opened and is cleared. Then the jejunum is divided. Then the jejunum is anastomosed to the pancreatic duct. So this way the pancreatic juice will directly come to the jejunum and will go into the body. So this is basically LPJ or a Pusto procedure. Okay. Now this procedure is basically we are opening the pancreatic duct and we have resected the head of the pancreas also. So this is a combined procedure which is a phrase procedure. And this third one is the duodenum is here, but the head of the pancreas has been removed. So we'll have to anastomose the jejunum to the remnant of the pancreas here. Okay, and this is actually a root limb of the jejunum to the remnant of the pancreas. Whole of the pancreatic head has been resolved. But the problem here is that the remaining pancreatic duct should be normal. Otherwise, in case if the duct is strictured here also, or if there is stone here, then this procedure is not going to work. So in patients with a head mass or with a normal rest of the pancreas, normal pancreatic duct, we can do this procedure, and the procedure is named as Weger's procedure. What we are doing here is DPPHR I have written the full form above. Duodenum preserving pancreatic head resection. Okay, so this is regarding chronic pancreatitis.